Dan, I'm sure our breast cancer colleagues dealt with this a decade or so ago, when you have a large number of options, many of which are have different mechanisms of action, and now we're seeing longer term survival, toxicities that can be chronic, some toxicities with the IOs that may require lifelong insulin replacement or steroid replacement. So many of the things that we never had to face a decade ago in kidney cancer, long-term toxicities, survivorship, quality of life, how do we start to pivot to ask and answer those questions for our patients in a way that's not really just agent specific, but disease generalizable?
Yeah, I think this is a great point. I'm glad you brought this up, because I think this is something that is starting to happen in a lot of cancer types, this concept of survivorship. And we typically think of it in terms of patients that are cured. But the reality is that these patients are survivors. They're going to live, a proportion of them, 4, 5 years or more. And understanding that there's a significant percentage of patients that are going to live that long, we need to start at the beginning with things like exercise and diet and other kind of lifestyle modifications to really minimize the chronic deterioration that will happen, the deconditioning and complications of patients. We need to rehabilitate patients as we switch from one therapy onto another. We've been very passive for the most part in our field about either studying this or about really advising patients about this. It's time, we as GU oncologists, and probably you guys in the community do this a lot more than we do already, because you deal with these other cancers where this is already ingrained a lot in there. But we need to start thinking about rehabilitating and reconditioning our patients. They do get hospitalizations, they get complications, they get skeletal events and other things. These are major setbacks, but there's opportunity on these agents to improve. David brought up the fact that quality of life improved actually for the first time in the Checkmate 025, and that's without any of this active instruction or intervention. If you actually intervene in this manner, you could probably make even a much greater impact on those patients. And the survival benefit downstream of that could be dramatic, because it could allow for that extra line of therapy or some other treatment effect that for them to tolerate that they might not otherwise tolerate, that could be a real life-prolonging benefit. So I think it's time. I think it's past time that we had the conversations up front. And I think we're in a unique situation because we have very targeted therapies in this field. We don't use generalized chemotherapy. We use VEGF-targeted therapy, which could have very specifically targeted effects on muscle, as well as vasculature and bone and other things. And so I say that because there may be strategies that could really make an impact in a positive way.
And I think that a recent article that was just in the Journal of Clinical Oncology, ASCO is trying to address this as they start to talk about the value of care. And the value of care initiative in cancer in a more generalizable way has been efficacy, toxicity, quality of life, and cost. And one thing that we haven't talked much about today, but I'm sure we will at a future meeting, is when you have 11 agents, soon to be more, maybe there are value conversations that need to take place to try and identify those things that are going to be different than the endpoints of a specific trial that get to survivorship, long-term toxicity, and the cost to society.